So we're going to talk chapter 35 today, geriatrics. We've seen through chapter 7 yesterday that as we age, things change a bit. Um, what we're going to go into today is just how much and the different things we can expect in presentation for our elderly patients and some of the other bits and pieces that go into assessing someone of an advanced age. GEMS is a class that you guys will be able to take for continuing education for EMT recertification down the road. And this GEMS diamond is sort of a bit of addition to our typical assessment, because normally we do our, scene size up, primary assessment, we get into that secondary medical assessment or our trauma assessment, and that's sort of where we live and breathe a little bit. But when we look at an elderly patient, there is more that goes into the assessment. As people advance in age, we need to look at their environment as well. As you get older and things start to break down a little bit and life becomes a little bit more difficult, we have to take into account that the things we see around this patient's house not only may give us some clues as to what their chronic medical conditions are, things like oxygen concentrators and multiple medications or a file of life tucked under the refrigerator, something in that sort. But we're also looking at, is the home well kept? Are there broken windows, and is there electricity? Is there heat? Is there anything that presents a tripping hazard? We look at the entire surroundings to make sure that this patient who is in a node of advanced age is well taken care of. Moving on down, yes, we get into our medical assessment. Not only as we get older do things start to wear out a little bit and we have possibly multiple different medical conditions sort of at play, we also then have to think about numerous pharmacological treatments for all of those things, plus over-the-counter medical medications that they may be taking. And, it helps us to really nail down our patient's medical history. When we talked shock, we talked about the different kinds of medicines that an elderly person may take that will make it so that they are unable to compensate for shock. I mentioned briefly beta blockers. That's something that we'll talk about as a treatment for hypertension. One of the things that does is it blocks the heart rate from being able to climb. It blocks the patient really from being able to raise their blood pressure. So two of the main early compensation mechanisms for shock are taken right off the plate if your patient is taking a medicine for hypertension that ends in OLOL. Things like labetalol, atenolol, they are beta blockers that are prescribed for hypertension, some different types of tachycardia they could be prescribed for, and they are things that are going to hamper our ability to cope with shock in an elderly patient. And then last but not least, we do a bit of a social assessment. Ask them about their families, ask them about spouse, grandkids, do people come and visit? Who helps them with their needs? It gives us an idea of how well their activities of daily living are being met. As you get older, you need sufficient social support for not just the physical part, but also the emotional part. You start getting older, people that are starting to pass away, friends are starting to pass away, family starting to pass away. It is absolutely possible that people of an advanced age will become sort of socially isolated, and sometimes they call 911 just because they need somebody to be there with them, and we can absolutely be that person.
Aging. What do you think of when you hear this word? What are your thoughts about older patients? How do older patients perceive you? The older population is growing. People are living to older ages and remaining more active throughout their lives. With the baby boomer generation, the number of people over age 65 is increasing. EMS providers can expect to see an increase in the need for care.
My name is Carlton Thomas. I've been an EMT since 1981. The greatest thing I've learned with working with older patients is they're the same as I am. The only difference is their individuality and freedom are at stake every time they leave their home. The greatest fear for a lot of our seniors is that when they return, things won't be the same as they left. The property may not be there, or the family is taken over and decisions are made for them that aren't made, that they never made before. And we have to look at their concerns as being as high a priority as their care. The greatest thing we need to remember is that standard that we give our seniors today will be the same standard that we can set for tomorrow. And as we are all getting older, we will all one day be needing EMS services.
The one thing that I think that anyone getting into this field needs to do is they really need to be very careful to listen to what the patient has to say. And they need to try to figure out maybe what questions they need to ask, because a lot of times we don't know just exactly what we should be telling them. So they need to do a lot of figuring as to what questions they need to ask.
As an emergency physician, the geriatric patient is a very challenging and often difficult patient to diagnose. Their signs and symptoms don't always come in the classic fashion that we're accustomed to. For instance, someone coming in with a myocardial infarction may not present with chest pain like the typical patient. They may have very vague symptoms that makes it very challenging and difficult to figure out exactly what's going on. Shortness of breath could be anything from congestive heart failure to a pulmonary embolism to simply anxiety over a situation at home. It's often very important for the EMS provider to get as many clues as possible while they're in the patient's environment and bring them back to the emergency department to help us with diagnosis of these patients. In addition to working in the emergency department, I'm also a medical director as well as a volunteer firefighter, rescue tech, and EMS provider. I've had the opportunity to go into these individuals' homes, and it's very important to gather as many clues as possible that will help in the diagnosis once the patient is delivered to the emergency department. Everything from their interactions with their family members and friends in their household to environmental clues, such as how warm or cold the house may be. Even bringing something as simple as the patient's medications into the emergency department can be immensely helpful in trying to figure out what the patient has wrong with them. Just doing these simple things can go very, very far in diagnosing the patient and helping the emergency physicians in taking care of these patients once they do get to the hospital.
For one thing, some of us get crotchety in our old age. Some of us have memory problems. Some of us have cognitive problems. All of us basically are very cognizant of the fact that we're on the downgrade. We have health problems, but we're worried about that. So the word compassion, which we talk about, is important. And it's important that you have to sort of go with care and slowly to make sure that your patient fully understands what you're trying to do and why, because it takes a sales job on your part to do that. When we leave our apartments, we worry about such things as our money, our jewelry, our personal effects, whether the door is locked. We have a pet, what's going to happen with a pet, and that sort of thing. There needs to be a certain amount of assurance given by the EMS team for the folks or the person who's going to be involved in being taken to the hospital, but not to worry, it'll be taken care of. We'll have all of the things that you need to go along with you.
I had experience about a year ago when the EMTs came and took me to the hospital with a stroke. They came very promptly. They treated me very well, both at the apartment and also on the way to the hospital. They took their time with me. I was very pleased with the treatment I got for the response team.
As an EMS provider, I consider it both a privilege and a challenge to care for the senior citizens in my area. The challenge comes because these senior citizens have age-related problems, and they oftentimes present atypically. They present atypically with chronic problems masking acute problems. Oftentimes, a lowered mental status can mean one of many things, and it's up to us to find out and determine exactly what is going on with this patient. Another aspect, geriatric patients tend to wait too long before they call for help, for medical help. Oftentimes, they have problems, as I said, chronic problems, and they're not readily able to deduce that there's something else happening and call for help immediately when something acute arrives.
The GEMS diamond was created to help you remember key concepts in providing emergency care to older patients. G's.
So my favorite part of that video was the guy who went, you know, some of us can be crotchety. Well, I'm knocking on the door of 40 and I can be crotchety. So I don't imagine what I'm going to be like at 80 something odd years old. But all of the things that they talked about there were very, very appropriate. They have an additional layer of concern when they leave the home. Am I going to ever be able to return to my home? Is somebody going to take care of my dog? Is the doors locked? Is somebody going to rob me? As you get older, these are things that are more at the forefront of your mind. And we need to, the statement of you need to do a little bit of a sales job is absolutely fact. You know, we need to make sure that we're explaining things, going slowly, even as that last paramedic said, you know, they wait too long. Old people never want to be a bother for some reason. They always think that they're bothering you. Which, you know, no matter how often you tell them, no, this is what we're here for. This is not a bother. You should call whenever you need to. You know, it doesn't pay to be in a rush and try to railroad them, because old folks get set in their ways. And once they decide, I'm not going, or I'm not doing this, or I'm not doing that, it's even more difficult to get them turned than, you know, if we were dealing with a pediatric patient. Go slow, take your time, explain things. When that gentleman talked about cognitive and mental impairments, one of the things that we need to never assume is that just because somebody's old, they've lost their faculties. I know people that personally that are 90 some odd years old and sharp as a tack and would finish a crossword puzzle before I would. Not to mention the fact that, yes, vision starts to go, hearing starts to go, but don't just walk in and begin sort of waving and yelling at your elderly patient, because it's not everybody. Some people will see and hear just fine right up into the time that they get super old and pass away. There's no real generalized structure for a lot of this. We're going to talk mostly today about the effects of aging on body systems, and we're going to talk some of the changes that we can expect to see over time. One of the things that they mentioned were chronic problems. That's those ongoing health issues that we talk about, those chronic illnesses that they're being treated by a doctor for. Don't be surprised if you ask, oh, do you have any medical problems? And if they've been prescribed something for high blood pressure, and you have their medical list right there in front of you, you have their list of medications, and you can see 3 different high blood pressure medicines on it, don't be surprised to hear the word no. Because when you ask, do you have any medical problems? No, I take a pill for that. It's not a problem. So work that into your assessment a little bit. You know, these medicines that you take every day, do you know what you take them for? You know, give them that open-ended question a little bit and let them run with it. Those chronic problems absolutely can turn into acute illnesses. We'll talk about that just a little bit. Illness is not an inevitable part of aging. You may have elderly patients that are just healthy as clams right up into their 90s and plus. It all is kind of a mixed bag, and we really kind of just need to lead our assessment, ask them the questions that, you know, we need the answers to, and make sure we give them the opportunity to answer them or rephrase a question if they don't really get sort of down to the nuts and bolts. That's another big thing that they mentioned in that video. You know, they don't really know sometimes what you're asking, because medical care has changed a whole awful lot since, you know, Grandpa was taking his combat lifesaver or combat medic training in World War II or Korea. So we are on the cutting edge of all this, and we really need to understand that the questions may not seem to make sense to them, and they might not come right up with the right answer. So let's talk about the cardiovascular system a little bit. Everything that we're going to talk about today is going to prove to us that getting old can be a real drag. And the better you care for yourself when you're young, the more likely you are to have a nice ripe old age without a whole bunch of problems. As we get older, there's degenerative processes all around, and we'll start with cardiovascular. The heart won't pump as effectively. We'll start to get calcium deposits on the valves, and maybe the valves don't open and close quite as well as they should. That will cause all sorts of other downstream issues if we're having heart valve problems and difficulty with the heart being able to pump. Stenosis is narrowing of a valve that will actually restrict blood flow through the heart. So left atrium ventricle, right atrium ventricle. We have valves. We have 4 major ones: tympanic, pulmonary, mitral, and aortic. And if those start to get stenosed and maybe don't seal quite as well, we'll have some backup into the lungs. We'll have some pulmonary edema, you know, sounding a lot like congestive heart failure. As we get older and blood pressure begins to go up. Oh, I want to be a Toys R Us kid. Blood pressure begins to go up, and we could have some cardiac hypertrophy. Cardiac hypertrophy is the thickening of the heart walls, so the muscle gets thicker. And if the heart muscle itself gets thicker, particularly in the left ventricle, it doesn't hold as much volume. So every heartbeat is actually not pumping out as much blood as it should be. It's really going to decrease the efficiency of some of our compensatory mechanisms, because when we try to increase heart rate, to increase stroke volume, to increase pressure and perfusion, if we can't fill that ventricle with enough blood, we wind up right in the same problem of not being able to get enough blood out. And if we can't get enough blood out, we can't get enough blood back. And it just is a negative loop cycle that will just continue to get worse. Orthostatic hypotension, we mentioned a little bit. That's, you know, your patient who stands up too quick and gets woozy. This is often a cause of some hardening in their arteries and decrease of the artery's ability to contract and keep blood pressure from dropping. Systolic blood pressure goes down, heart rate goes up, and you'll see your patient sort of get dizzy and want to tip over. And it's all a result of the stiffening of the arteries through arteriosclerosis and inability to regulate their blood pressure. Next, we're going to talk about the respiratory system. Sad fact of the matter is, almost every part of the respiratory system can deteriorate over time. It's really as a result of alteration in the muscles and the elasticity of the lungs and the thorax itself. Bones become a bit more stiff and brittle. We actually have a decrease in the size of the muscles used for respiration. So those intercostal muscles between the sternum and the ribs and the diaphragm really just sort of decrease and become less pliable. And that means the elderly patient will have less expansion and contraction to move gas from the outside to the inside. There'll be less smooth muscle fibers to support the smaller structures, and it diminishes the airflow actually getting down to those alveolar ducts so that we can have the external respiration of oxygen out of the alveoli and into the blood, and carbon dioxide out of the blood and into the alveoli, so that we can exhale that and pump all that newly oxygenated blood around. So we may have elderly patients that have a bit of retained CO2 and switch to that hypoxic drive that we talked about. With the diminishing of all this muscular and nervous structure, we will have a decreased resistance to infection. They don't have the ability to cough quite as forcefully and get out some of the crud that we would be able to just cough up. Foreign particles will get trapped in that mucus lining, they can't get it out, and we wind up with things like aspiration pneumonia, and that can be just absolutely deadly to an elderly patient. Moving right along, we're getting to the neurological system. The brain will actually decrease in size, and the amount of cerebrospinal fluid will take up that extra space. So we'll have a decreased amount of brain tissue. Some of the ability of the body to control its functions is going to become a little less efficient. We'll have changes in the brainstem. We'll have changes just about everywhere. The elderly generally don't eat a lot and don't drink a lot because they have altered ability to actually perceive hunger and thirst. We have a lot of sensory problems. It will diminish over time. It'll be your everyday senses like your hearing, your vision, your smell, touch, pain, hot, cold, you name it. And that is part of the reason that, when we think of our stereotypical elderly patient, that they don't always have the stereotypical complaints that we think of with things like heart attack. They mentioned that in the video. An elderly patient having a whopping myocardial infarction may only ever complain of some shortness of breath or some just very general malaise, like I just don't feel quite right. I walked across the kitchen and got real tired and had to sit down. Does that point you towards this patient could be having an MI and I should be giving them aspirin and maybe nitro? Because it really doesn't trigger that in my mind until I start adding some other things into my assessment of this patient to try and figure out, well, do they have a cardiac history? Has anything like this ever happened to you before, maybe? And you start investigating and digging a little deeper, because this neuropathy is causing difficulty with the way that they actually sense the problem that's going on with them. Next, we'll get into the GI tract. All right, so we had some deterioration and reduction in our ability to smell and taste. Then possibly some breakdown in the structures of the mouth, and up to and including, teeth and gums and jaw structure. And we have a drop in saliva, so it becomes a whole lot less pleasing and pleasurable to actually eat food, just the process of eating it. And then when we get down to that fact that peristalsis is slowed and now food doesn't move through the digestive tract quite as well as it used to, and every time you eat, you develop some constipation and it's difficult to go to the bathroom and you always feel full and you never want to eat, we'll see some pretty marked malnutrition in some elderly folks sometimes as part of their sort of environmental and social structure part of the assessment. And in conjunction with our medical assessment, we'll start to see that, they probably need a little bit more support than they're getting. The endocrine system, we've talked pretty well at length about what can happen to the pancreas. We'll have some increase in hormones. The pancreas's only job is not just insulin, and the endocrine system is not just insulin. We'll have an increase in blood pressure. So that's part of the reason that a lot of these elderly folks will wind up on things like beta blockers, is because their own hormones are acting inside of their blood and acting on some of those receptors inside to sort of naturally, as a product of all this, raise their blood pressure. They'll have some problems with fluid retention and congestive heart failure based on some of this stuff. Their pancreas may not quite be up to snuff anymore, and it may not be up to the task of producing all the insulin that this patient needs, and we'll start to see some type 2 diabetes begin to develop. Or maybe the insulin is still working just fine. You know, the pancreas is creating it and pumping it out, and the receptors down at the cellular level just aren't as responsive to that insulin, and we can start to see some elevation in our patient's blood glucose just based on the fact that things are wearing out. Now we've gotten to our musculoskeletal system. We see osteoporosis is probably one of the biggest, more significant changes we see as a product of aging. The bones will become a lot more brittle and very much more susceptible to fractures. And then the backside of osteoporosis is it also slows the healing process. We will have some significant structural changes to the musculoskeletal system. And when we get a little bit further along here, we'll talk some more about changes to the integumentary system, so the skin that covers that musculoskeletal system. Kyphosis is generally seen along the entire spine, but it's most pronounced in the thoracic vertebrae, so we see it more there. The discs between the vertebrae will actually start to narrow, causing the spine to curve a little bit and give that sort of hunchbacked look to our patient's spine. That's one of the things that I always talk about when we talk backboarding and cervical spine immobilization. You know, when it was an elderly person, it was very difficult to appropriately attach them to a backboard, because if my elderly patient had kyphosis or any other cervical abnormalities, I would need all the padding in the world to make that backboard fit them, because I'm not going to try and force their thoracic spine back into a position that maybe it hasn't been able to be extended to for 20 plus years. We'll start to see some arthritis and some decreased range of motion and flexibility. Joints will sometimes need to be replaced. We'll start to see problems with motion in general, and the fact that, you know, it is just painful for old folks to move around sometimes. Moving right along to the renal system, the kidneys, they're responsible for filtering all the crud out of our blood, and they become smaller. They also become less able to filter out all of that crud. They lose some of their filtration ability based on that decrease in size and change in the nephrons over time. We'll have a problem then with electrolytes, which are integral in nerve tissue doing their job and the heart being able to beat. And we will have an increase in just extra fluid throughout the body based on the fact that the kidneys are starting to break down a little bit. Now, add to the fact, we talked about pharmacology here for a minute. A lot of medicines, since the kidney's job is to filter, a lot of medicines, especially antibiotics, are nephrotoxic. They are toxic to the kidneys and the nephrons that are supposed to help filter out our blood. So if our elderly patient wasn't taking their medicine appropriately, or had made some mistakes in their normal dosing routine of, I take this pill and then 12 hours later I take this pill, or maybe they took it two together, we'll start to see some more damage to the kidney, and more damage to the kidney means lesser filtration, and we start to see maybe some acute renal failure starting. The integumentary system, this changes one whole bunch. skin becomes a whole lot thinner. You'll see elderly patients sometimes have this almost like tissue paper-like consistency to their epidermis. The subcutaneous tissue actually begins to break down, and they wind up with less of it. The epidermis and the dermis aren't as attached with tissue. So that's why you'll start to see some of those wrinkles and skin tears just by, you can unfortunately just like drag your finger across the skin of an elderly patient sometimes and open a wound. We'll start to see sores from not moving around enough. So our elderly patient who spends a lot of time just sitting can develop some of those decubitus ulcers and pressure sores from just being in the same position all the time and not moving around. We see them a lot of the times on the tailbone, the coccyx, or the calcaneus, the backs of the heels. We have less perspiration is produced, and there'll be a problem with their sense of touch. So it'll be difficult to discern as an elderly person hot versus cold, and they don't perspire as much, and they're always cold. So we may never really even get to see some of the product of them being too warm. But really, the integumentary system beginning to break down a little bit is just a diminished amount of protection. It's a diminished amount of protection from microorganisms, so we'll see more infection. It's not as adequate as a shock absorber, so if there's falls, generally the structures underneath are going to be injured. And we see just all of these changes sort of stacking up, making diagnosis and treatment on our side sort of difficult, and really making the fact that getting older is just difficult in and of itself. No, I guess there's no video there. All right. So we're going to talk here about some special geriatric assessment findings. What we're going to get into is things that should trigger your spidey sense just a little bit when we're doing our assessment. And the first one we'll talk about is the absence of chest pain with a patient who is quite likely having a heart attack. Elderly folks will have what is called silent MIs a lot of the time. Elderly females particularly. Generally, younger folks, when they're having a heart attack, the decrease in oxygenated blood flow and nutrients being supplied to the heart produces chest pain. Since we have a decreased sensation and decreased perception of pain, elderly folks a lot of times will have some very general complaints, like I mentioned: weakness, fatigue, confusion, dizziness, nausea, vomiting, abdominal pain, syncope. Do any of these things sound like chest pain? Come on, that wasn't rhetorical.
No, it doesn't.
No, it doesn't. So what do we use to now, when we get those things, because a lot of that just sounds like, well, I'm old. How do we use those things to make an accurate field sort of clinical decision for this patient?
Their history?
Their history indeed, and their list of medications. If we find nitro on scene, well, it's a pretty good indicator that our patient has a heart problem. If we ask them about that nitroglycerin and then they start talking about, heart attack and hypertension and high cholesterol, we can start, dotting our I's and crossing our T's a little bit. And then we can ask them, hey, does this feel like the last time you had some heart trouble? And then, you'll see, again, like Dawn on Marblehead, and they'll say, yeah, this is a lot like the last time I had to go in for some stints, because it's never stent, it's stint, S-T-I-N-T. Why, I don't know. And, then you can start figuring out, does this patient meet criteria for aspirin and nitro and maybe some oxygen if their complaint was respiratory in nature. And we start sort of working down that acute coronary syndrome path when we had a very general complaint that didn't really initially ring to us as a patient having an MI. Congestive heart failure is a big one. We talked about the heart weakening over time. We see this very, very common. It is a chronic condition. It can also become an acute condition. Generally, it's caused by some sort of cardiac disease causing backup in the peripheral blood vessels. This is going to be your patient who says, oh, I take a water pill, and you check their lower extremities and they're all filled with fluid. And when we listen to their chest, we'll hear some of those crackles that we expect. Or if it's really, really acute and they're really having a hard time, we will see pulmonary edema. Pulmonary edema is all of that fluid and all of that bloody substance collecting around those pulmonary capillary beds. And we may even see, that pink tinged sputum and just beginning to flow out of our patient. And it's all generally as a result of the heart losing its ability to pump appropriately, fluid backing up and winding up in places that it's not supposed to, depending on which side we have the failure. And the complaint for this is generally respiratory in nature. You may have no indication whatsoever that you're dealing with a heart failure patient, because you'll get a call for altered mental status and difficulty breathing and just respiratory distress or nausea, vomiting. And you'll show up and your patient will look like that science fair volcano from 7th grade with pink foamy stuff just pouring out of them, and the almost absolute abject look of terror on their face because they can't breathe and they can't get any gas to exchange through all of that built up fluid. And it's just a condition that continues on its merry way to not doing well. Our treatment for it is pretty simple. It's going to be oxygen at 15 liters per minute in a non-rebreather mask. We may wind up ventilating this patient with a BVM. Down the road someday, maybe we'll talk about continuous positive airway pressure, or CPAP. We won't do that today because we don't need to. And really, it just is a product of the heart's inability to function as a pump anymore effectively. Pulmonary embolism is another thing that we may see causing some shortness of breath in our elderly patient. Pulmonary embolism is a blockage of the artery that leads to the lung for that blood to be oxygenated. We'll have an embolism of some sort. Generally, it's very, very sudden onset difficulty breathing. Maybe some chest pain that's localized and not radiated. Maybe some syncope. A lot of these things, again, are just an absolute mixed bag with our elderly folks. But get the good history, get the good information as best you can from either them or somebody that's there with them. And the treatment for anything respiratory in nature really is the same. We're going to look for an ALS intercept because they'll be able to do some things on the more advanced side that can correct some of these problems. We're going to oxygenate, and if oxygenating is not enough, we're going to ventilate. And if ventilating isn't an option, maybe we reach into our bag of tricks for some other things. And we're going to sit this patient upright on the stretcher, because the last thing they need to do is lay down and make their respiratory distress worse. Or if we're ventilating, of course, we're going to lay them down. It's, be prepared to have to change your treatment modalities and move yourself in different directions as patient condition indicates. Pneumonia is something that very rapidly can turn into a septic shock situation with our elderly patient, because on top of now their lungs being compromised, their immune system is also going to be compromised. They're more susceptible to disease. Their inability to cough and clear out any of that disease-causing processes is just not going to be really to their benefit. Aspiration pneumonia from accidentally aspirating food or vomitus into the lungs. Their airway is losing some of its ability to do its thing. We have decrease in those muscles of the respiratory system. We have decreased ability to cough. Things that you or I would just be able to cough right out and have no problem with can really lead to a systemic and or fatal infection for these folks and really turn into a tricky emergency right out of the gate. Care is generally still going to be supportive. Airway, breathing, circulation, high flow O2. We're going to transport them in position of comfort. Generally, that's going to be in the Fowler's position, sitting up. Push comes to shove, we ventilate. This is respiratory in nature, so we treat it as a respiratory condition. COPD, well, most of these folks were alive back before cigarettes were bad for you. And we do see some problems with emphysema and chronic bronchitis. We talked at length about this when we did the respiratory lecture. As far as assessment goes, you could hear just about anything in this patient's chest. You could hear wheezes, you could hear crackles, you could hear that raucous breathing because they have the chronic bronchitis and all sorts of crud in their chest. Complaint, well, respiratory call and the world is round, so the complaint is generally going to be some form of respiratory in nature. If this patient has a prescribed albuterol inhaler, we would be able to help them out with that because we have signs of a reactive airway disease. They have difficulty breathing with a rescue inhaler. So if they haven't maxed out their dose, we help them with that. If their breathing ever becomes inadequate, well, we switch right into ventilation. If we can just oxygenate and medicate if we can, great. Signs and symptoms of a stroke. This game doesn't change a whole bunch. Anybody remember that BFAST stroke scale? Nobody?
It was on like face for F,
Okay.
actions for A, oh, and then speech
Now the
for.
lady, the A is what this woman's doing right here on the screen.
Oh, okay. And it was like T for time, right?
Yeah, so we want B is balance. So do we have any new problems with our patient being able to hold themselves upright? E is any new onset problems with their eyes, their vision. F is face, so we would have them smile. In that video where they were interviewing those elderly folks and we saw that woman who said she had a stroke, did anybody notice that she still had some problems with the symmetry of her face, that the muscles really hadn't come back fully? So we've gotten the B, E, and the F. Sandy, since you started answering, what's this lady checking right here with her arms? What's she doing?
I don't remember the word, but I know it's when you close your eyes and
Okay,
then like
yeah.
to like lift one side of your body up, like something along those lines.
We have her hold both of her arms out in front of her with her thumbs pointed out and her palms pointed up and close her eyes. And the likelihood of her having a stroke will be if one of those arms all by itself just begins to drift back down into the anatomical position of laying like at her side, like how someone would normally sit. That is one of the things that's going to be an indicator that tells us that the patient may be having a stroke. And the S, speech, we're going to ask them to say something difficult to repeat. You know, she sells seashells down by the seashore. The sky is blue in Boston. And if we have a positive finding on that, the patient will sort of slur their words and stammer their way through that and have a difficult time saying it. Any one of those things is enough for us to think that our patient may be having a stroke. The more things that they get sort of botched on this test, the more the likelihood increases that they're having problems and could be having a stroke. TIA, generally considered to be mini strokes, right? They are strokes that signs and symptoms reverse all on their own within 24 hours. It is a precursor generally for a patient who's going to have a stroke. I think the thing we saw yesterday was like 1/3 of patients who have a TIA have a stroke in the near future, and about 5% have a stroke within the month. We are going to treat this the exact same way as we would a patient who is having what we consider a real live actual stroke. We're not just going to hang out in grandma's house and wait and see if she's having a CVA or not. We are going to transport to the closest appropriate facility with an ALS intercept en route. All right, so we're going to get into some altered mental status here, but we have been cracking on here for about an hour. So before we get into dementia and delirium and Alzheimer's and all that stuff, probably a good place to take a short break. Why don't we come back in about 10 minutes and we will put the finishing touches on this lecture and get going on the last one. All right, folks, we are back from break and we are going to talk about dementia and delirium. Dementia is just a result of malfunction of normal brain activity. It's chronic, it's irreversible. It can be severely worsened by things like infection. These are times where we see things like our normally pleasantly confused elderly person who has sepsis from, say, something like a urinary tract infection is now sort of holding people at bay with a pencil or throwing things at staff. It can be changed and made worse by trauma, changes in medications, really any other acute processes that are going to affect our patient can affect our patient with dementia that much worse. It says about 15% of people over the age of 65 develop dementia, and it can result in some profound disturbances in their ability to function mentally. Delirium, on the other hand, is more sudden in onset. Dementia is a developing disease. Delirium is a disease that has a lot of the same effects, a lot of the same causes, but it is just quick. It may present with sudden change in mental status. It could have actual delusions and people seeing and hearing things that aren't really there. But it is generally the difference, sort of the defining line is dementia is a progressive disease that continues to get worse. Delirium has a more sudden, rapid onset. Both going to be chronic changes in cognition. They are both going to be intellectually based. But remember that dementia is more long-term changes in intellectual abilities. So it's a steady sort of decline in their ability to make judgments. Pick a cause and you'll be able to find something that is relatable to patients developing dementia and delirium. They don't really have a hugely great handle on what causes these things because the list of things that can be possible causes are innumerable. Our emergency medical care for these problems in particular are to make sure we're not missing something. Make sure we're not missing a septic infection. Make sure we're not missing a low blood sugar or a patient who's having a stroke or myocardial infarction. You know, go through and dot all your I's and cross all your T's. Just because it comes in as altered mental status, It could be altered mental status because of hypoxia. It could be altered mental status because of hypoperfusion. It could be altered mental status because of hypoglycemia. Start checking off the things that we know we can fix. Hypoxia, oxygenate. Hypoperfusion, oxygenate. Hypoglycemia, we're going to check a blood sugar and then treat accordingly. So start working through some of your possible causes of this altered mental status and make sure that something isn't being overlooked. Alzheimer's disease is not a disease that generally causes death directly. Alzheimer's disease is believed to affect about 2 million people and cause more than 100,000 deaths every year. But a lot of the cause and effect with Alzheimer's disease, it will cause people to stop eating. It will cause people to become immobile and not move around anymore. They'll be bed confined. We'll have susceptibility to infection. Dementia is generally linked to Alzheimer's sort of hand in hand. Alzheimer's is just a generalized breakdown of everything. Nerve cells and brain tissue cells just degenerate and die. It is progressive and global in nature. It involves the entire central nervous system, which means it involves the entire body. There's no real treatment. There's no cure. What we're looking for is in the early stages, it'll mimic diseases like depression, just some general irritability. A patient who has sort of uncharacteristic violence with lucid periods. So sometimes they're normal and having a great day. Other times, again, they're like the old woman trying to hold people off and hold people at bay. Eventually, as it progresses into the late stages, they become more childlike. They have difficulty recognizing loved ones. Caring for these folks can often be pretty difficult. Emergency care for these folks can often be pretty difficult. It's just, you have to be very, very compassionate in nature and willing to spend a whole extra amount of time trying to get them cooperative and get them sort of calmed and relaxed to a point where you can at least transport them, because getting some assessment out of them could be difficult, even with just trying to do a physical exam. They may ask the same questions over and over and over and over again. Just continue to give them that same answer that you've given them every time. Just reinforce what it is that you're trying to do and provide your supportive care and transport.
Trauma is the fifth leading cause of death in older patients, accounting for 34% of deaths in patients 65 and older, despite the fact that they only account for 14% of the trauma population. The most common causes of trauma in the older population are falls, motor vehicle collisions, and burns. It's estimated that around 30% of people living independently who are over 65 fall each year, and about half of these patients suffer multiple falls per year. It's important to note that patients who are institutionalized suffer from a 50% rate of falls annually. EMS providers should also understand that the likelihood of experiencing a fall increases with age, and that falls are the leading cause of traumatic brain injuries. While older patients are not involved in as many motor vehicle collisions as younger patients, their injuries are often much more severe. Older pedestrians who are struck by motor vehicles also have a significantly higher mortality rate. Older patients account for 13% of patients in burn units. These patients also suffer from higher body surface areas burned, higher mortality rate, and longer hospital stays. Due to the high likelihood of comorbidities, particularly musculoskeletal disorders, the possibility of blood thinner use, and the changes that occur with aging, older patients who are involved in trauma tend to experience more severe injuries and take longer to recover. Changes in the pulmonary system predispose patients to the buildup of atelectasis and pneumonia. Changes to the cardiovascular system inhibit the older patient's ability to compensate for shock. Lastly, changes to the brain increase the likelihood of head injuries. Osteoporosis, osteoarthritis, and rheumatoid arthritis place the older patient at risk for increased bone and joint injuries. Some injuries, such as rib fractures, can cause a disruption to the patient's ability to breathe, while other injuries, like hip fractures, can cause the patient to exsanguinate quickly. EMS providers should not assume that cases older patients involved in trauma is solely trauma in origin. It is imperative that EMS providers research the cause of the traumatic event to determine if the traumatic event is caused by a medical emergency. Ask the patient what was going on when the event occurred and see if their description provides any clues to a medical condition that may have occurred. If the patient is unresponsive or having difficulty communicating, providers should attempt to gather a medical history through available evidence. Providers may notice a vertical scar in the center of the chest, a pacemaker, dialysis shunt, medical alert bracelet, oxygen tubing. EMS providers should try to determine the cause of the patient's fall. Did the patient trip? Over what? Were they dizzy first? Do they remember falling? Did they hit their head? After answering all these questions, providers should have an idea if a medical issue caused the fall or if they fell from a trip hazard. If trip hazards are present, providers should take note of this so. Remember, EMS is more than patient assessment and management. EMS providers must be patient advocates. Part of this is teaching the public about trip hazards and fall prevention. EMS providers should watch out for signs of shock. Find out how long the patient has been lying on the floor. Hypothermia and/or crush syndrome may also be present if the patient has been lying on a hard and/or cold floor for any length of time. The most likely form of shock and trauma is hypovolemic. EMS providers should be aware that due to patients' medications, beta blockers and ACE inhibitors in particular, older patients may not present with the typical tachycardia and hypotension that is associated with hypovolemic shock. This should be managed by maintaining thermal regulation. Make sure to cover the patient up with warm blankets and ensure that the heater is on in the patient compartment. ALS providers should initiate an IV and begin fluid resuscitation to maintain a systolic blood pressure of 100. If rales or other signs of congestive heart failure are present, then fluid should be used with caution. Medical control can be contacted regarding fluid resuscitation versus use of pressors to maintain adequate blood pressure. If spinal motion restriction is indicated, providers should attempt to place a C-collar on the patient and use a multi-person lift. Many locations have restricted the use of backboards due to the lack of research of effectiveness and multiple studies of harm to skin and minute volume and causality of pain. If a backboard is still required, then particular attention must be paid to pad the board around any voids. Several layers of folded blankets should be used between the patient and the rigid device. If a kyphosis is present, a great deal of padding may be needed. If the patient is lying on any sheets or the backboard is covered, ensure to remove any wrinkles so the risk for decubitus ulcers is minimized. Remember, patients can develop decubitus ulcers on backboards in very short periods of time. Pain and decubiti have been proven to start in as little as 20 minutes of a patient lying on a rigid device. Even in short transport, think of the time at the ED. Consider analgesia if the patient is in acute pain. Differentiating acute versus chronic pain can be complicated, but patients can usually help guide you. If acute pain is present and the patient is hemodynamically stable, consider administering fentanyl or morphine. Providers should consider reducing the amount of analgesics by 20 to 40%. EMS providers must take an active role in injury prevention. EMS can work with other entities, to help older patients understand their medications, ensure their home is safe, and ensure they have the appropriate assistive devices in accordance with their activities of daily living. Medications can be complicated to understand. Some patients may have misconceptions about the need for retaining old medications or unfamiliar with how to dispose of them. Medication reviews, along with vital sign assessment, can help identify medication issues early. If EMS systems do regular home visits to ensure patients' homes are safe, patient 911 calls will reduce and patient hospital stays will reduce. If patients have proper footwear, clear pathways, and good lighting throughout their home, they will be less likely to fall. Hip protectors and fall alarms will help protect patients if falls do occur.
Okay, so what we're going to talk about here with elderly folks and trauma is an ounce of prevention over a pound of cure. The best time to help and sort of correct some of these issues with our elderly patient or their family is at the time of the injury occurrence. You know, that's why they're talking about do that environmental assessment some, and you know, if there's trip hazards, throw rugs, things aren't appropriately secured, they have extension cords running all over the place, 19 miles of oxygen tubing snaking throughout their house. That's the time. Strike while the iron's hot. Yes, you're responsible for patient care, but some of our patient care priority also needs to be, how could this have been prevented so that it doesn't happen again? So falls are hugely detrimental to the elderly population. Anyone over the age of 65 will receive spinal motion restriction here in the great state of Massachusetts. For the rest of class, we'll talk specifically about backboard. We're going to backboard these people. We need to try and get to the bottom of why they had this fall, though. One of the more important things is to figure out which came first, the chicken or the egg. Did this patient feel dizzy? Did they have some fluttering feeling in their chest? Did they have just a syncopal? Did they trip? Did something happen medically to cause them to have this fall? Because if it did, those things don't just go away once they hit the floor. We need to go and investigate that a little deeper to try and figure out, is there still an ongoing acute medical issue that is making this patient sicker than they present just from the trauma? You add to that the fact that now the brain occupies less space inside the skull, and we see higher incidence of things like head injuries. It's going to be treat like we would any other trauma patient and be very, very aggressive treating for shock, keeping them warm. Just an overnight on a tile floor can really be extremely detrimental to an elderly person after a fall when we start talking about things like skin breakdown and inability to thermoregulate. You know, they can already be well behind the 8 ball when it comes to dealing with shock. And, you know, we need to recognize that we might not see what we're looking for when we start talking hypoperfusion. GI bleeds are generally are just sort of a product of getting older. Tissues become softer. We have backup in the GI system itself. We have things like diverticulitis, which are just going to continue to irritate and aggravate the area, which just is a problem with our elderly folks. We're looking for hematemesis. Hematemesis is the $10 fancy medical word for vomiting of blood. Hematochezia, and these are words that you will probably see again. Hint, hint, hint. I've seen these on the National Registry exam. So hematemesis, vomiting of frank blood, just looks like blood. Hematochezia is red undigested blood in a bowel movement. Melena is dark tarry stools, so a dark tarry look to their bowel movement. The hematemesis is also something we look for with that coffee ground-like substance that will vomit up with an upper GI bleed, because the stomach won't break down the iron in our blood. It won't break down those red blood cells, so it just kind of clumps them all together and makes just kind of a gross, all types of disgusting mess. Treat for shock. This is something that can cause pretty profound hypovolemic shock. We are going to oxygenate, keep them warm. We're going to transport them supine, monitor their vital signs, treat their ABCs accordingly, and make sure that we are providing for them everything we can to make sure that this doesn't get any worse.
So Tommy, you said hemotemesis for the vomiting blood. What was the second one you said?
Hematochezia is the passing of blood in stool. Let me just make sure I get those two right. Yeah, fresh blood through the anus in a bowel movement. So now let's get into our actual assessment and the way we should approach these folks. So all of this really should at this point be able to go without saying. We're going to approach with concern and consideration. We've already talked pretty well about social issues faced by the elderly. We can add into the fact that, you know, as they're getting older, they're starting to sort of become familiar with, you know, people that they're close to not being around anymore, and they're beginning to become familiar with their own mortality. They also have the subject of loss of their independence if they've had a fall and have a hip injury and wind up in a nursing home, or loss of the ability to live on their own and have to move in with their kids, or they have financial problems that will have them making some decisions about their future. And it's, you know, it's a big confrontation for them. This avoid ageism. That is really just saying, don't just assume that they're a crusty old person. Don't just assume that since they're old, you have to yell. Don't just assume that since they're old that you know, they can't see you or they can't understand you. We should be judged by the way we treat our elderly folks, and it oftentimes would not be a very nice judgment. I personally, when it comes to what patient would I rather deal with, I love elderly people. One of my partners used to joke about me having a collection of old ladies, and I think they're great. I love talking with them. I love hanging out with them. They are just, you know, the best patients most of the time, and they are so grateful and so like happy when you remember them and happy when you ask them about their kids and their grandkids and stuff. And it really is sort of, you know, they are not going to be around forever. I've driven around with B-29 pilots from World War II. I've met some of the more interesting octogenarians that I could ever even imagine. And I treat them as such. You know, this is something that I kind of personally think, as a society, we could be better at. And then now that's not to say that, you know, respect your elders, because I live in a homeowners association with some of the nastiest old people you'd ever want to meet. And if I had to meet them professionally, I'd still have to be nice to them. But that doesn't mean I want to be buddies with them. And, you know, the B-29 pilot, my partner and I drove around with this man for an extra 35 minutes because he was cool to talk to. At one point, my partner, when we got to the place we were dropping him off, my partner climbed in the back of the ambulance and we had a 15-minute conversation with this guy. He was a stable patient. He was being discharged after like a hip surgery or something. So it wasn't like, you know, he was dying and we farted around. He was a cool guy to talk to. So we hung out with him for an hour or so longer than we really needed to that day. Don't tell OEMS because they'd be mad at me. I am just checking to see here if we missed anything. And this is the last little bit we're going to talk about here. These are our treatment priorities. These really are our treatment priorities for anyone and everyone. And it doesn't really change a whole bunch just because somebody got old. When there's nothing else to do, we're going to maintain a patent airway. We're going to insert an airway adjunct if we need to. We're going to assess and be prepared to assist them with their ventilations. We're going to establish oxygen, 15 liters per minute with a non-rebreather mask. We're going to position the patient in a position of comfort or however we need to transport them appropriately. We're going to transport them to the closest appropriate facility. We're going to do our secondary assessment. So our sample and our OPQ-RST, we're going to get a baseline vital signs. We're going to treat what we can. If they're a trauma patient, we're going to do that head to toe. We'll do a focused physical exam. We'll correct any of the problems that we found that we can. And then we're going to leave. We're going to transport them to the emergency room. We're going to reassess every 5 minutes because they are a critically ill patient until proven otherwise. And we are just going to start our reassessment right back at the beginning, going through mental status, level of consciousness, general impression, airway, breathing, circulation, reassess any of our treatments, provide any other treatments as indicated, and the beat goes on. We don't change. We do everything the same way. We just might have to add a few bits and pieces to get the information that we need for a geriatric patient. All right, that was, but we do have